Hi everyone. So we're going to start in a couple of minutes. I'm just waiting for some of the presenters to join in, and we can start in a couple of minutes. So if any one of you wants to give an update, go ahead. Or we can start with questions if you have any questions for now.
Hi, Dr. Nader.
Hello, hello. How are you?
Hey, Dr. Nader. How everyone?
Very good. How are you today?
Great, thank you.
Excellent. We are waiting for the customer, and then we can start. Next one. So hello everyone, and today we can start our meeting, and I hope the presenters are ready. Here are the topics that we're gonna cover: pulmonary, and followed by organizational skills, and we'll talk about this presentation or test report. Last part will be about t-test as tutorial or the tool that you can use for analysis, and later we can talk about the update. So without ado, if Dr. Batran, are you ready? If you're ready, you can share your screen.
I'm ready, yes.
Go ahead then. Thank you.
Dr. Salma, can you please share your screen for me?
Hi, Dr. Batran. I'm just trying to get my mic to work. I will share it in a minute. Can you hear me?
We can.
Yes, Dr.
Okay, okay, just a second.
So while the customer is uploading the file, I just want to share with you that in the coming days, weeks, you're gonna go through the ERAS application. And if you want to request a letter from me, this is the information on the app. So you can put my name and title, email. It will come to me, then I will write the letter and upload it to the ERAS system. So just in case you want this to be done, as soon as you feel you are ready, please do send the request. Sometimes I ask you to remind me with the products that you are doing. So if you did not do it last week, I hope you will be able to do it this week. If you go to the current product list, I'm going to share it also with you through the chat now. Please keep it updated with your name so that I can mention that you are working on this and that project. If it's been accepted, you can write that it's been accepted to this or that conference, for instance. So thank you so much.
All right, I am ready for you.
Go ahead.
Thank you. Can you see this, Bertrand?
Yes.
Okay, go ahead, it's all yours.
Okay, I would like to start off by thanking Dr. Salma for moderating the presentations today, and to thank Dr. Nader for this great opportunity. Today, I'll be talking about respiratory disease and disorders. We will hopefully learn how to evaluate common respiratory symptoms, help patients quit smoking using the 5 A's, recognize and treat major pulmonary disease and disorders in older patients, as well as making decisions regarding end-of-life mechanical ventilation. Topics covered include age-related pulmonary alterations, common respiratory complaints and symptoms, major pulmonary diseases in older persons, and intensive care of the critically ill. Age-related pulmonary alterations include reduced airway size, shallow alveolar sacs, reduced chest wall compliance, intercostal muscle atrophy, and reduction in diaphragmatic strength by 25%. Recognizing respiratory symptoms in the elderly can be difficult. Approaches to diagnosis and treatment. A common misperception is that older people tend to overestimate or exaggerate respiratory symptoms. The opposite is more often true. Older patients often have more than one explanation for their problems, which include dyspnea, cough, and wheezing. They can overlap. They can have more than one of these symptoms at once. The causes may include a combination of diseases, such as asthma or emphysema, obstructive sleep apnea, heart failure, and reflux disease. For rhinosinusitis, the diagnosis and treatment for the most part are the same, regardless of age. However, there are special considerations for senior patients who may have geriatric rhinitis, which is a common but often neglected or overlooked condition because it is not life-threatening. Symptoms of geriatric rhinitis include constant feeling of nasal drainage, chronic or uncontrolled need to clear the throat of mucus, sense of nasal obstruction, often while lying down, nasal crusting during the winter and with diuretic use, and a decreased sense of smell and taste. Bacterial rhinitis is treated with saline irrigation, and if the symptoms worsen after 7 days, we administer antibiotics. Chronic rhinosinusitis is treated with saline irrigation and intranasal corticosteroids. Allergic rhinosinusitis is treated by the avoidance of triggers. When it comes to dyspnea, common causes to consider are COPD, cardiac disease, asthma, interstitial lung disease, and deconditioning. Dyspnea does not necessarily correlate with oxygenation or pulmonary function tests, but a thorough history and physical exam can help tailor the testing and the treatment choices. The language a patient uses to describe dyspnea can be revealing. Heavy may imply cardiac dysfunction or deconditioning, and tight may imply angina or asthma. Common causes of chronic cough are usually benign. These include postnasal drip, asthma, and reflux disease. Empiric treatment for these conditions is a reasonable approach. A patient may have more than one of these conditions, so treatment for multiple causes may be warranted. As for wheezing, it indicates airflow limitation. Common causes include asthma and postnasal drip, but it can be also seen in COPD as well as idiopathic pulmonary fibrosis. Pulmonary edema is associated with heart failure and may present as cardiac asthma. Airway hyperresponsiveness from chronic bronchitis is not uncommon in older patients with a history of wheezing and sputum and tobacco use. Major pulmonary disease in older persons include asthma, COPD, obstructive sleep apnea, idiopathic pulmonary fibrosis, pulmonary thromboembolism, pneumonia, and lung cancer. Uh, 5 to 10% of people 65 and older meet the criteria for obstruction and bronchial hyperreactivity. Asthma is under-recognized and undertreated in older adults. 50% of all asthma deaths are in people 65 and older. Treatment for asthma include intranasal corticosteroids or other controller drugs such as mast cell stabilizers, leukotriene receptor antagonists, and we want to use the lowest effective dose. Beta agonist should be used as needed as reliever medication. Instruct the proper use of PEF monitoring because of the older person's decreased perception of bronchoconstriction. Commonly used medication so I think there's a slide before this. Thank you. Commonly used medications are beta agonists, and the list is there: the albuterol, levobuterol, formoterol, forbuterol, and salmeterol. Some are short-acting, some are long-acting. Corticosteroids, which can be intranasal or oral is usually prednisone. It's not on the list. It's taken for refractory asthma, and IV methylprednisone for exacerbations. Others include like chromalin and nidochromyl, mast cell stabilizers, ipratropium and triotropium, leukotriene, anticholinergics, and combinations of intranasal corticosteroids and long-acting beta agonists. Long-acting beta agonists should never be taken alone. The epidemiology of COPD affects about 15 million people in the US. It's the 4th most common cause of death. after heart disease, cancer, and stroke. The prevalence and mortality rate is increasing, especially in older people. The morbidity and mortality from COPD accounts for more than $15 billion per year in US medical care expenditure, mainly due to hospitalization. COPD diagnosis. Wheezing is the best predictor of airflow limitation. Patients with obstructive airflow limitation are 36 times more likely to have wheezing than are patients without this problem. Other predictors include barrel-shaped chest, hyperresonance on percussion, and a forced expiratory time greater than 9 seconds measured during the clinical examination. These are usually seen in bronchitis. In emphysema, we would see pulmonary hypertension and its complications. The guidelines, gold guidelines for COPD, the key factors for considering a diagnosis of COPD is dyspnea, chronic cough, sputum production, and the risk factors, presence of risk factors. Dyspnea is usually progressive or worsens over time, as well as with exercise. It's persistent and is described as an increased effort to breathe, heaviness, air hunger, or gasping. Chronic cough may be intermittent and non-productive. Sputum production can indicate any pattern of chronic sputum production can indicate COPD. Risk factors are smoking, occupational dust and chemicals, and smoke from home cooking and heating fuel. Spirometric classification of COPD is a FEV1 over FVC less than 70. However, some experts recommend using a FEV1 over FVC less than 65 after the age of 70, because the changes seen may be related to structural changes that occur in the airways with increased aging. Mild COPD is a FEV1 that is greater than or equal to 80% predicted. Moderate is greater than 50, but less than 80. Severe is greater than or equal to 30, but less than 50. Very severe is when the FEV1 is less than 30 of predicted or less than 50 with a chronic respiratory failure. The five A's to help patients quit smoking are ask, assess, advise, assist, and arrange. Ask the patient about use of tobacco at every office visit. Assess readiness to quit. Advise patients to quit. Assist patients in the quit attempt with aids such as a local sedation program and pharmacological agents such as bupropion or nicotine replacement. Arrange both a quiet date and a follow-up visit or contact to discuss the quit attempt. Smoking cessation slows decline. Slows the decline of
Do you want me to go back to the first slide?
Yes, please. Smoking cessation slows decline in lung function at any age.
Okay.
This is the guidelines for COPD therapy. For mild, we just use a short-acting beta agonist. Usually we just add a anticholinergic. For moderate or another bronchodilator, but usually it's anticholinergic. For severe COPD, we can add inhaled steroids, especially if there's more than 2 exacerbations per year, or rehabilitation. For very severe, we could add long-term oxygenation therapy, especially if there's respiratory failure. Other interventions for COPD are oxygen therapy, exercise training, respiratory therapy and education, treatment for major depression and anxiety, because it is present in 40% of COPD patients. Anxiety may lead patients to seek help in ER or be admitted to the hospital. Obstructive sleep apnea typically presents with neurocognitive impairment, morning headache, and poor sleep. Patients are typically obese and hypertensive with large neck circumference. It's diagnosed by a sleep study. Central sleep apnea is associated with stroke and myocardial infarction. Sleep apnea is often undiagnosed and therefore untreated. Treatment options for sleep apnea are weight loss, avoidance of alcohol and sedatives, sleeping on one side or upright, correction of metabolic disorders such as hypothyroidism, and CPAP. Idiopathic pulmonary fibrosis is relentlessly progressive. The median survival is 3 to 5 years. Normal presentation includes insidious dyspnea and cough. Clubbing is often a prominent finding and can distinguish pulmonary fibrosis from emphysema. It's commonly treated with oral corticosteroids, but only 10 to 20% of patients respond, and adverse effects are often prominent. Early referral to a subspecialist is warranted if patient wishes to consider further therapy. Pulmonary embolism triples from age 65 to age 90. Age greater than 70 is a risk factor for misdiagnosis. Blood gas is normal in 10 to 20% of patients. The diagnostic workup is the same as in younger patients. And there's a 10% recurrence rate within 1 year. Anticoagulation is guided by the same principles as in younger adults. In older patients, it may be even more important to achieve therapeutic levels of heparinization quickly. Use of outpatient low molecular weight heparin while achieving anticoagulation with warfarin is supported by well-designed trials. Allow an overlap of 1 to 3 days between heparinization and adequate warfarin therapy with INR target of 2 to 3. In most cases, anticoagulation therapy should continue for at least 6 months. Intensive care of the critically ill. A support study showed physician error rates in approximating patient preference for mechanical ventilation. There was 36% for patients are less than 50 and 79% for patients greater than 80. Physicians should be more consistent in attempts to elicit patients' preference for do not resuscitate orders. The decision to use mechanical ventilation should not be based on age alone. Unlike general medical ICU population, patients with acute lung injury and acute respiratory distress syndrome appear to have higher mortality with advancing age. Acute lung injury patients require nearly twice as long to be liberated from the ventilator. Comorbidities often contribute to death in acute lung injury. Cognitive decline often dramatically worsens after an ICU stay and becomes a major threat to quality of life. Study of 851 patients receiving mechanical ventilation shows that 63% were successfully liberated, 17% died while receiving mechanical ventilation, and 20% had mechanical ventilation withdrawn. The AMA recommends a standardized, fair process rather than a strict definition of futility. Rather than chronological age alone, futility decisions should be based on factors such as clinical efficacy of treatment, likelihood of mortality, subsequent quality of life. In summary, with age, there is a decline in forced vital capacity, FEV1, partial oxygen, while the AA gradient increases. 5 to 10% of people 65 and older meet the criteria for asthma. Smoking cessation may slow the decline in lung function at any age. Most patients with COPD derive little or no benefit from routine intranasal corticosteroids, but a brief course of systemic corticosteroids may reduce the duration of an acute exacerbation. Older people recover pulmonary physiology at the same rate as younger cohorts, but in some diseases, they may require a longer time to be liberated from the ventilator. So now we go to the questions. Question 1. A 72-year-old man comes to the office for evaluation of dyspnea that has progressed slowly over 6 years. He has COPD and has used albuterol as needed for 6 years. He has a daily non-productive cough and wheezes intermittently. He can no longer participate in activities such as golf. 6 months ago, he had an exacerbation of COPD requiring prednisone. He has never been hospitalized or gone to the emergency room. He quit smoking 3 months ago. On examination, temperature is 36 degrees Celsius. Blood pressure is 145 over 85. Heart rate is 96 beats per minute. And respiratory rate is 22 breaths per minute. There is no accessory muscle use. Bibasilar cracks are audible, and exhalation is slightly prolonged. Cardiac examination is normal. There is a trace ankle edema, but no cyanosis or clubbing. Oxygen saturation on room air is 93%. Chest radiography displays hyperinflated lungs. Pulmonary function tests show FVC, 85% are predicted. FEV1, 60% are predicted. And FEV1 over FVC is 60%. After treatment with a bronchodilator, FEV1 increases by 11% and FVC increases by 10%.
So these are, Patron, if you don't mind me interjecting. So that's the case. The question is, in addition to continuing albuterol as needed, which of the following is the most appropriate treatment at this time? Albuterol, 6 hourly, ipratropium bromide, 6 hourly, combination albuterol, ipratropium, 6 hourly, tiotropium once every 24 hours, or inhaled corticosteroids. So these are the options. I'm going to repeat them again. So albuterol, ipratropium, albuterol, ipratropium, tiotropium, or inhaled corticosteroids.
Is there a slide by chance?
There is a slide, but it has the answer. But I can share it. It's okay.
Oh, no, I mean, it's okay. Yeah, you might as well. Yeah, okay.
There we go. It's so those were the options, and then those were the answers.
So this is actually a hard question because ipratropium and tiotropium, they're both anticholinergics. However, tiotropium is longer acting. Has longer acting duration, and it's also it's proven to lead to fewer exacerbations, fewer hospital admission, and improved quality of life. So although they're both anticholinergics, tiotropium, because it's longer acting, is the right answer. Because he has COPD, and it's just moderate. It's chronic COPD, but it's like moderate. So we just add an anticholinergic. Case 2. A 75-year-old man is evaluated because he has sudden onset of shortness of breath, sharp pleuritic left-sided chest pain, and cough productive of blood-tinged sputum. He had elective hip replacement surgery 6 days ago. He has been and is wearing pneumatic compression devices on both legs. He has a 20-year history of COPD. He is taking a proton pump inhibitor for duodenal ulcer diagnosed 2 weeks ago and albuterol as needed. Temperature is 38 degrees Celsius. Blood pressure is 165/90. Heart rate is 110 beats per minute. Respiratory rate is 26 breaths per minute. There is no accessory muscle use. The patient has slight expiratory wheezing. There is no jugular vein distension. A left-sided S4 gallop is audible. The abdomen is soft without masses or hepatosplenomegaly. There is no cyanosis, clubbing, edema, or thigh or calf pain. White blood cell count is 13,800 with 85% polymorphonuclear cells and 6% bands. On ELISA, D dimer is less than 500. Arterial blood gas on room air shows a pH of 7.48, partial oxygen of 70, partial CO2 of 30. An ECG reveals sinus tachycardia. Chest radiography reveals left lobar lobe atelectasis or infiltrate. VQ scan indicates a low probability for pulmonary embolism. Bilateral low extremity Doppler ultrasound demonstrates no evidence of deep vein thrombosis. Which of the following is the most appropriate next step? A, treat with heparin. B, place an inferior vena cava filter. C, treat with antibiotics and steroids. D, obtain CT of chest. E, obtain CT angiography of chest.
I think everyone agrees. The majority agrees on.
Yes, correct. The answer is E. Because despite the high probability of pulmonary, he has a high probability of pulmonary embolism, but his VQ scan and Doppler are normal. So the next step is a pulmonary angiogram or CT chest, spiral CT with contrast. Case 3, a 70-year-old retired mailman comes to the office because he now has difficulty climbing one flight of stairs. He has dyspnea on exertion that has progressed slowly over 5 years. He wheezes occasionally. He has had a minimally productive morning cough for many years, but no chest pain or discomfort. He has a 50-pack year cigarette smoking history and still smokes. Temperature is 36 degrees Celsius. 115, blood pressure is 115 over 75. Heart rate is 98 beats per minute. Respiratory rate is 22 beats per minute. Arterial blood gas on room air shows a P. There's no accessory muscle use. Bibasilar crackles are audible. Cardiac and abdominal examination are normal. There is trace peripheral edema and mild clubbing, but no cyanosis. Chest radiography is normal. Pulmonary function test show FVC 65% are predicted. FEV1 70% are predicted. FEV1 over FVC ratio is 75%. After bronchodilation, FEV1 increases by 9% and FVC increases by 8%. Which of the following is the most likely cause of this patient's dyspnea? A, asthma, B, COPD, C, idiopathic pulmonary fibrosis, D, pleural effusion, E, pulmonary embolism. Yes, correct. First, we have a FEV1 over FVC ratio of 75%. COPD is classified as FEV1 over FVC less than 70. Secondly, we have clubbing. And secondly, we have clubbing that helps distinguish it from COPD. Any questions?
Thank you so much for this
Thank
great
you for
presentation.
listening. Thank you.
Thank you, Dr. Patron, for this great presentation. And if you have any questions, please raise your hand. And okay, go ahead, Dr. Anna.
Hi, everyone. Thank you so much, Dr. Batran, for this amazing presentation. Actually, I don't have a question, but I have an interesting case when I was working on the ER. So I want to share with you. So I remember that I have seen a patient when I was working in the ER. He was a male, I think in his 60s, but I'm not very sure about that. So he was a prisoner. I remember that the police brought this patient from the jail to the ER because he was complaining of syncopal attacks. So when I examined the patient, I noticed that he was morbidly obese. So I think I did not measure the BMI, but I think it's more than 40. So, and I noticed that his neck is also very large. So when I took the history from the patient, he told me that he has difficulty sleeping at night and that he has mood changes as well. Also, he developed palpitations. Maybe the palpitations were the cause of his syncopal attacks, and that his mood changes that he developed as a result maybe of obstructive sleep apnea, I don't know. So his mood changes was the cause of him being in jail because he was in a fight with someone. So I was wondering if all these findings, the weight and the arrhythmia, mood changes, can point to an underlying unrecognized obstructive sleep apnea because he never received a diagnosis like that. So I was an ER physician, and the decision of diagnosing and admitting the patient was not my decision. So eventually the internal medicine team arrived, and I discussed my findings with them. They admitted the patient, and unfortunately I lost follow-up with him because I'm just an ER physician. That's why I don't like the ER specialty, because there is no long-term follow-up. So I actually don't know what happened to the patient after that, but he was very interesting case. He looked very sad, and I felt very sad for him.
Thank you so much for sharing, Dr. Amal. It's great case to demonstrate. So you can see and observe the findings. You can do the examination, starting with inspection, and then when you do other part of the exam, you can find some clues basically to indicate whether or not you have the right diagnosis. Thank you for sharing. Thanks.
You're welcome.
If no other questions, we can jump to the next topic. Thank you so much.
Hello, everyone. My name is Sarah El Shafi, and I'll be doing the second topic for today. It's time management and organizational skills. So let me just share my screen. Okay. Okay, can everyone see my screen?
Yes.
Okay, so time management and organizational skills. So this is a very important skill that we need in our daily life, especially with our professional career. So there is a need for time management and organization skills. There's like 24 hours in a day. We all know this. Research shows for a person to be healthy, roughly a person needs 7 to 8 hours of sleep, and that leaves about 16 to 17 hours for everything else to be done in a day. So you go to school, you go to work, you spend about an average of 3 to 10 hours. When you study in a lecture hall, or if you're taking night courses, a lecture, for every 2 hours in a lecture, you're supposed to study an hour. So that can equate to 6 hours a day. Eating is an hour. Shower, getting ready for the day can take from 30 minutes to an hour. Exercise, again, 30 minutes to an hour. And then routine maintenance. So just doing chores around the house, your laundry, paying the bills, whatever, all that can equate to an hour per day. And then non-school and non-work interest is an hour. And then relaxing and having fun, you're allowed to relax and have fun for about 30 to 1 hour. And time with family and friends, whether it's face-to-face, going out for coffee, going out to the mall, or via phone call, it should be about 30 minutes to an hour. Now, this estimate does not include time spent on transportation and or unexpected events, like going to a hospital or other activities. This is just an average. It's a very rough estimation. You don't have to follow this exactly down to the numbers, but it's just to show how time should be spent for someone to be healthy. So time is one of the most valuable resources we have. So there's several philosophies that have been iterated about time. So I'm sure you've all heard this. The gift of your time is the most valuable gift you can give. If you want to know what people's real values are, look at how they spend their time and their money. Time is money. I'm sure we've all heard that. Time management is not about managing time, it is about managing yourself. So there's like many advances in technology and other areas are all about saving time. Time is very valuable. It's a very valuable resource in our life. What happens when we do poor time management? So poor time management, it's again, time management and organization skills are important both personally and professionally. But if we have to deal with poor time management, this can lead to frustration and stress. It's physically detrimental for your health. It can lead to failure to complete daily tasks or achieve personal and professional goals. And we can be considered a less reliable and less responsible individual. And the personal safety and patient safety can be compromised. So there's common myths and pitfalls. I'm sure we've all heard this, and we've all said this to ourselves at one point in our life. I don't have the time. Saying that is actually a lie. The truth is that we all have 24 hours in every day to accomplish what we need and what we want. The difference is how we choose to spend our time. So instead of the next time that you feel compelled to say, I don't have the time, for example, let's say, I don't have the time to spend time with my family, rephrase it instead and say, I can't take the time to spend time with my family, because then you'll feel the need and obligation to change that and do something about it and find time to spend with your family. I'm too busy. You choose how to spend your time. If you feel that you're too busy, you need to change your schedule and you need to try to reduce your tasks. Do not take on as many tasks. Don't overwork yourself, basically. You need to find your success limit and maintain it. And then, contrary to the popular belief, the busier people are, the more productive they are, and the more they accomplish. Actually, that's sometimes not true. This does not apply for every single busy person. It's important to recharge your batteries once in a while, but if ever the going seems easy, check to see if you're going downhill. You need to reevaluate yourself if you feel like life is going too easy. Because feeling consistent stress and guilt if you relax at all, or if you get off the task, these are not healthy feelings to feel. And it can escalate to illness and exhaustion. You're going to stress yourself out. You have to have a balance between getting things accomplished, but not that your schedule is so easy that you're wasting your potential to achieve higher goals. So you need to find a balance. And everything is different for everyone. You have to experiment and keep trying different things. My personal time management skills have nothing to do with how I manage time at work. This may be possible, but rare and unusual. At home, it's because we are proactive. We determine when we want to do what we want to do. Because you're at home, there's no rules. Medicine practice is often reactive. At work, we help patients when they ask for it, when they need it. So this is reactive. These different situations give the impression that personal and professional time management differ from each other. So we do not usually purposefully apply different criteria for how we manage our time at home versus work. These skills are unconscious, they are routine, and they are a habit. These skills can be learned. Another myth is I need time to focus in order to. So the ability to multitask is an absolute necessity for any doctor or medical student / graduate. It does not mean doing several things simultaneously. So if so, the patient's safety can actually be compromised. You don't want to do too many things at once. It's going to lead to a mistake. It's going to increase the risk for a mistake. And you might mess things up. You need to have the ability to switch gears easily and maintain a sharp mind so that you can give your undivided attention for a few minutes to the hand and then move on to the next task or back to the original task. So it's actually very rare that you have the entire day to work on one single task. You're usually doing a lot of tasks, but you have to find a way to balance them. I'm a perfectionist, so important to do your best and to always. So as a doctor or medical student graduate with many demands on your time, it is critical that you discern which task must be perfect and which can be less than perfect. It is okay not to be perfect all the time unless the consequences of not being perfect is severe. So we shouldn't be too hard on ourselves if it's not required in that particular task. So there's actually a lot of theories and practice of time management. I just listed one of the popular ones. So Drucker, 1967, articulated 4 suggestions for helping executives to better manage their time. So number 1, find out exactly how you actually use your time. Number 2, determine what does and does not have to be done, and then discontinue doing the latter. Number 3 is delegate work to others who are equally or better qualified than you are. And number 4, stop wasting other people's time. Another person is Morgenstern in the year 2000. He compares between time and space and describes each day as a container, a storage unit that has a definite capacity you can reach. Sorry, it's a female. Her book walks the reader through 4 phases. So the first phase is laying the foundation, thinking about creating a time management system that works for you. Number 2, analyzing, defining your personal style, preference, needs, and goal. Number 3, strategizing, mapping your ideal schedule and staying on track. And number 4, attacking, putting your plan into action. And then we've also got Merlin Paul, and the year 2003 offers a 7-step path to becoming truly organized. she likes to incorporate mental, physical, emotional, and spiritual aspects of one's life into the context of getting organized and thus living a better life. Her book is very interesting. This is the book, The 7-Step Path to Becoming Truly Organized. It's hard to make a difference when you can't find your keys. That's the title of the book. Time management in practice is based on 2 issues. So in our daily practice, we're all doctors. How organized you personally are at work. Can you work well in a scattered, chaotic environment, or must you work in a very structured and systematic fashion? And then what the workflow is like in your environment. Now, note, most of us have some control over one, but not always over the 2. So we're going to talk about time management tips for physicians, what they can do. So real-time management and how to do it. The steps, the themes involved in practicing better time management. There's 6 of them. So the first one is recognize the need for improvement. Number 2 is to conduct an honest self-reflection or analysis of how you currently use your time. Number 3, establish your mission and set goals. Number 4, get organized, sort through your tasks, create a master list, schedule tasks, use a system to help you get organized. And then number 5 is to take action. And number 6 is to review, revise, and modify. So we're going to go through all these 6 steps. So number 1, recognizing the need for improvement. So almost all the literature that describes a successful behavior has at one point all concluded that the recognition that one's behavior needs to change or that a person desires to change his or her behavior. If one has not decided this, the chances of being able to improve are much less. So you need to, from yourself, you have to recognize that you want to change. You have to have the desire to change. Otherwise, it's just pointless. Number 2 is conducting an honest self-reflection or analysis of how you currently use your time. So you need to ask yourself some key questions to identify problem areas and how you should best plan your time based on your personal preference and style. It's useful to keep a time journal, document how you spend your time in blocks of 15 minutes, and keep it with you at all times to document activities for an entire week and be honest. After a week, analyze areas where time could have been better spent and evaluate factors that could have contributed to wasting time. And then asking a coworker or a significant other or a family member or anyone who's living with you at home to observe your habits for 1 week and provide some constructive feedback. And then be sure also not to be too hard on yourself and to reward your hard work. So if you were studying for example, 3 to 4 hours straight, you can give yourself a minute break. And then for the second round, you can get a 30 to an hour break, depending on what you like. Number 3, establish your missions and set goals. So writing a personal mission, all your goals, your priorities, they will flow. Write out rough ideas and then edit and refine them. Begin with the end in mind is the most effective. So knowing your end goal exactly, you start with the idea is very useful. Setting short and long-term personal and professional goals is critical to help determine priorities and stay focused. So we have something called SMART. It's a useful tool. It stands for specific, measurable, achievable, realistic, and timed goals. So this is the criteria for your goal. So goals should be number 1, specific. The more specific a goal is, the more direction it provides, and the easier it is to measure progress. So for example, studying more versus the number of hours. Number 2, goals should be measurable. So you need to try to quantify the specifics in your goal. Number 3, goals should be achievable. You should not be set so high, it shouldn't be unrealistic, unachievable. So for example, a famous singer with no talent. Motivation increases with the goals are higher. So if your goal is so high, you may never start. If it's too hard, you might chicken out and not want to do it. Number 4, goals should be realistic. take into account available time, resources, and skills. Goals should be timed, much more likely to achieve if it has a target date, which increases motivation, commitment, and action. So number 4 on the 6th list is getting organized. So sorting through your task, we said creating a master list, prioritizing tasks, scheduling tasks, and using a system to help you get organized. For example, is a calendar. You can use a calendar. Also, technology is very useful. We have a digital calendar. We have Google Calendar. It helps sets up alarms for important projects and deadlines. So there's a lot going on in this modern time. So general tips from the experts. To help be organized and to help with your time management. So take care of yourself. To be productive and successful, number 1 is to take care of yourself. Eat healthy, sleep well. 7 to 8 hours is the most recommended hours of sleep. And exercise. You need to have a healthy body, healthy mind, healthy mental health. Most people do their best work in the morning. But it's also okay if you're a night owl. Me personally, I do my best work at night. So do what best works for you. Schedule meetings and less intensive activities in the afternoon. Again, experiment. If that works for you, good for you. Check your phone messages only twice a day, in the morning and in the afternoon. Our phone can be very distracting. It is a source of entertainment. You can get lost watching YouTube videos. Nowadays, people are addicted to TikTok and I don't know, like games. So they tell you to try to minimize social media and using your phone for entertainment. That's why it's telling you to check your phone twice a day. Cluster tasks and activities in the same place together when possible. And then also, the amount that you do does not always equal the quality of your work. And how busy you are sometimes also does not equal how productive you can get. And working harder does not also mean that you can work smarter. And then reward yourself. Rewarding yourself so that your motivation can stay high and you're more productive. So number 5 is to take action. Some of the realities of human nature and how we normally spend our time. So what we like to do before we do what we don't like to do. Like, that's so true. I like to do the easier thing before doing something that I absolutely hate. For example, let's say I'm doing chores around the house and between folding the laundry and washing the dishes, I absolutely hate doing kitchen work. So I'd rather fold my laundry before and leave the dishes last thing. We tackle what we know how to do faster than what we don't know how to do. Again, that is very true. If you know how to do something compared to something that you have poor skills in doing, you're going to do it faster. We do activities that we have resources for. We do things that are scheduled before non-scheduled things. We also respond to demands of others before our own demands. And then we wait until a deadline approaches before we really get moving on projects. That's like the number one thing that a procrastinator does. They do their work last minute. I mean, I'm guilty of that myself. During medicine school, whenever we've all done it. There are all times where during an exam, sometimes you can get disorganized, you lose track of your schedule, and sometimes a pop quiz approaches and you can't help but cram like last minute all the stuff that you're supposed to study weeks ago. You can't help but sometimes cram it the night or the 2 days before the exam. So we're human. We're human. It can happen. Being aware of some of these patterns, though, can help better help you to avoid them. So being aware you're most likely be able to identify it in the future, and it's just you're reminded to try to do it less. So 3 actions to help you overcome bad habits: minimize interruptions, so unexpected events and their impact. You need to conquer procrastination and chronic lateness, and you need to overcome perfectionism. So it's again, experimenting, practicing, and hopefully everyone can help overcome these bad habits. And then number 6, the final thing is to review, revise, and modify. So it's important periodically to review all the steps that you went through to determine if your system is working well. Are you accomplishing tasks and goals to your satisfaction? Are you feeling less stressed than before? Do you procrastinate less often? Have your preference or style changed in any way? Do you want to try out a new organizational system? Have your goals or priorities changed? And then what major changes have occurred in your life to modify your goals and priorities? So these are like important questions to ask yourself when you want to review, revise, and modify. Also, for those with bad habits, just like a quick summary, there's something called the 7-step cycle of change. I thought this is a useful graph to help with this. So it starts off, there's like 3 stages, as you can see. So the stage 1 is the ending, stage 2 is the transition, and stage 3 is the new beginnings. So it starts with denial. You can see that the motivation and performance is kind of low. You deny the fact that you want to change, and then you realize there's a realization that that something needs to change, and there's shock and confusion. You can't help, but there's actually resistance, anger, blame, and defensive for the change, because sometimes it's hard to admit that you want to change. It's human nature. You can't help but want to resist the change, but then eventually you let go. But at this time, it's the lowest point of your motivation and performance. And then stage 2 begins, transition. There's anxiety, there's fear, uncertainty, frustration, searching. And then eventually there's understanding change, and some optimism, and some ideas will begin to bloom. And then you enter stage 3, which is new beginnings. Change is accepted. There's commitment, enthusiasm, there's trust. And as you can see, at this point, you're at the highest level for your motivation and performance. So this is the 7-step cycle of change. Also, I want to talk about useful tools that you can use to help you keep organized and to help with your time management. So there's lots of, you can make one up yourself, or you can write it out, or you can print out PDF templates of calendars and schedules. So I'm just going to show you the 3 common schedules. So this is a daily schedule template for the 7 days of the week, and you can just see, like, you can do one by hour, you can do one by priority, you can do one by deadline. It depends. There's honestly so many designs and templates online. There's the weekly schedule, as you can see here. By the week, you want to see, sometimes people want to see their projects and their deadlines and their work schedule by the week, so that's also useful. And then there's the month. The month is also useful for important events coming up and important things that you got to do. Again, that's the monthly. And then for goals, you can have a journal. Writing out your goals is sometimes very effective for people. There's academic goals, social goals, health goal, personal goal. There's like lots of different types of goals and aspects that you can do in your life. And then also, me personally, I like the Pomodora technique. I like to use it especially for studying. So for those who don't know what the Pomodora technique is, it's a simple method to balance focus with deliberate breaks. So it helps plan your task. It depends on how many Pomodoras you might need. So it's basically a timer. I personally, I don't do 25 minutes. I do 50 minutes. And then like for each 50 minutes, you want to give yourself a 5-minute break. And for example, if you finish 4 rounds of Pomodoro, then you can take a longer break. So, but as you can see here, they have, they do 25, some people 25-minute works well, especially if you are a person who loses focus easily, you can do 25 minutes. Again, you experiment, you test it out. It depends on what works for you. Everyone's different. And also to reinforce the Pomodoro technique, there's this website that I love. It's free. It's a very useful free tool. It's called lifeat.io. This is a screenshot of what it looks like, and it has a Pomodoro timer on it. I'm actually going to show you what it looks like on the internet. So I have it here pulled up on the website. So it's basically a workspace. For me, I like it because it helps, I don't know, seeing like a nice view is very motivating for me. So if it says here, so use life out here, there, and everywhere, feeling stuck at home or in the office, losing focus and feeling burnt out. Some people, it has music on it. Some people like that, listening to background music as they study. There's classical music too, and there's it doesn't necessarily have music with words. It's just background music. So there's you can build your productivity with using a dashboard. There's a to-do list, the Pomodoro, the Spotify notes. There's a lot of things on it, as you can see. And it helps track your daily focus. It says cut off 2 hours of work time per day by building a habit in 7 days using the daily streak. So as you can see here. And you can also work with coworkers. As you can see, you can actually do a video chat with them. So it achieves maximum accountability by inviting your friends and colleagues to your room. I'll show you when to enter the website, click on go to app, which is on the right corner right here. And this is how it looks like. So as you can see, it shuffles random pictures and videos and windows. So here it loaded something called Riley Beach in Thailand. So as you can see, you can minimize the tab on the left-hand side. So I'm gonna minimize. If you wanna open it on full screen, you can. If you have a second screen, like for example, if you have a laptop and an iPad, you can have it on the iPad while you're working on the laptop. And you can see here, there's the timer. The timer says 20 minutes here. If you click on the setting button under the start, you can actually edit the timer. So I can change this. Like I said, I like to use 50 minutes. So you can do 50 minutes and then take a 5-minute break. And then after 4 rounds, it will give me a longer break. And it plays a timer volume. So this is also very useful. You can move it around, as you can see here. And you can minimize it if it's in the way. And there's just a lot of very nice things on it here. There's a study with me if you want, I believe. And there's a cafe. So for example, if you click on the coffee symbol, it opens random coffee shop that is very aesthetically pleasing. It's a recorded loop video of people sitting in a cafe. So as you can see, for example, here, there's those 2 ladies there sitting there. So it looks like you're sitting in a cafe. There's window if you like to see random views from the, I don't know, they have like a lot of, they have a lot of things here. And I believe there's a study with me. They have study with random people. If you like to, if your friends, for example, all bailed on you or no one's available and you want to study with someone, you're feeling lonely, you can use this. It's nice. And Again, there's the to-do list and the notes, it's all there. Okay, so that's that website. Conclusion, real change takes time and old habits are hard to break. It's okay if you did not follow your plan to the T. Celebrate your success, learn from your failures, keep striving to improve. And as long as you're making progress towards your goal, that is what is most important. Again, we're human. We will never have complete control over all our time. So just, it's okay. And as long as you practice and you're working hard and you try to work towards breaking your bad habits and your procrastination habits, then over time, hopefully we will all, inshallah, be successful. Thank you for listening. Any questions?
Thank you so much, Dr. Salva. This is a really excellent presentation as well. Thank you both, Papa and Sarah. Any questions? It's really interesting topic, and thank you so much. So next, we can go to the next agenda. When you're ready.
Yeah, our next agenda. Yeah, Dr. Hassan, go ahead.
Yeah. Hello, everyone. Hi, Dr. Nader.
Hi.
My name is Hassan Al-Haj. Before I start, I want to thank Dr. Nader for giving me this opportunity to talk about this interesting topic. And I want to thank everyone for attending today, and I hope you enjoyed. Let me share my slide here. Can you see the slide?
Yes.
All right. So today we will talk about writing a clinical vignette, case report, abstract. So case report. Case reports represent the oldest and most familiar form of medical communication. Many original observations are first presented as case reports. Like scientific abstracts, the case reports is governed by rules. It has rules that dictates its format and its length. As Sir William Osler said, scientific observations carefully documented, so that may be a valuable education and research resource. So what is the study design of case reports? It's a descriptive study, and in depth, it's a naturalistic and qualitative. And as we all know, it's usually a retrospective study, as it's not a pre-planned research. This is the hierarchy of evidences in research papers. This is the pyramid, as all of us know it. As we go from the bottom to the top, the quality of the hierarchy of the evidence. We start from the bottom with the expert opinion, then the case report, case control study, and cohort study. And at the top of the pyramid, we have the meta-analysis and the systemic review. So what is the history of the case report? The features of the clinical case report in different time periods were discussed. within the earliest Egyptian records, they talked about the incurable tumors of the breast. We have also melanoma by the Hippocrates in the 5th century. We have also in January, like in 1832, the Hodgkin's lymphoma by Thomas Hodgkin. We have also here in 1941, Stacy Gelt from Johns Hopkins University. He described a glomus body in the human temporal bone, and the famous acquired immunodeficiency syndrome, AIDS, discovered on the basis of a case report. We have the extensively disseminated Kaposi sarcoma in the American Journal of Dermatopathology in 1981. All right, so what are the types of case report? We have diagnostic, assessment reports, we have treatment or management reports, and we have educational reports. The diagnostic or assessment reports, they describe and discuss the rare, confusing, or difficult cases. We have also the treatment or management reports. They include the full management and assessment with in-depth understanding. We have also the educational reports or the CMA reports, which include brief review of the literature to provide current practice strategies, or all cases with new and innovative perspective view. Here we have the publishable case reports. They might include an unusual or an unknown disorder or clinical presentation. We expect to see that in most of the publishable case reports. It might also present a challenging differential diagnosis, pointing to an unusual etiology for a case, or describing mistakes in healthcare and their consequences and causes. It might also include or present information with the ethical question. Publishable case reports may also include the pointing in favor or against a hypothesis. It might also illustrate or support a hypothesis also. It may also stimulate further research or offer a new insight into a disease. Or to report unusual, like drug food or drug nutrient interactions. It may also describe improved or unique technical procedures. So in which section you will publish the case report? You might include it in sections in peer-reviewed journal, in the case report sections, or as a clinical case in a conference, or technical report, or letter to the editor, even a evidence-based case report. So for writing a case report. Planning is very important. Careful planning is essential for all good research projects and good scientific writing. So always take time to plan, to write the sections, the subsections, the paragraphs, and the sentences. It takes time. Here we have the three major questions we should always ask ourselves is, what am I going to report? How should I report it? And in which journal? These are the major sections that should be included in each case report. The first one is the title and the other information. Second one is the introduction and the objectives, the literature review. The third one is the description of the case report. And we have the fourth one is the discussion with the case summary. And finally, the conclusion. We will go through each one by details. So you will need also supplementary materials to write a case report. You need tables, you need figures, you need graphs, you need illustrations. Usually the case reports around 1,500 to 2,500 words. And usually the number of references around 15 references. So abstract writing. So we write the abstract lastly, the last thing to be done, and we polish it till it is just right. And we try as much as possible to be like either word limited, structured with headings, or unstructured, like single paragraph. And we'll have an example at the end of this presentation. And very important to not have any abbreviation or references. So if you want to tell, always spell out the abbreviations the first time they are mentioned. So if they are mentioned for the first time, try to spell them out for the first time, unless they are like commonly organized or recognized by the people like the CBC abbreviation. So for the abstract, please state briefly the conclusion and state how it will influence in practice or advancement in knowledge. Also the keywords, the words representing the main content, around 3 to 10. For an abstract writing, it typically takes like several days to write a good abstract. And the process should not be undertaken alone. So always try to get help from a mentor who is not familiar with the case, because the mentor can quickly point out the areas that are unclear or demand more detail. Then after that, you can make revisions based upon the feedback. And also, and finally, make the others read the draft for you in order to check the technical errors, such as the spelling and the grammar mistakes. Another way you can read the abstract out loud is another way, so that you can catch by yourself the awkward phrasings and word omissions. All right, the first section is the title and author information. So at the beginning, you provide the title with the full name of the author and its institutional address and the email address, indicating the corresponding author. All right. Here at the title, we have to put in mind that title is the summary of the abstract itself. So it always should like convince the reader that the topic is very important and relevant, and it's something innovative. And you have to also don't tell everything about the case in the title, because the reader's interest might lack. So the title should be descriptive, accurate, and succinct. The introduction. An introduction of the case report describe the subject, concise and salient, to clarify the background of the information and the evidences you have, and also state and the strategy of the literature search, the date and the database, the language, the search terms. It should be like easily reproducible and must cover the relevant database. Also in the introduction, justify the case report. Always begin by what is known, then move to what is new, and highlight the implication. Introduce the case to the reader, and it's very important to select the references very carefully. limit its length, and try as much as you can. Don't overinflate the discussion. So the case presentation. For the case presentation, we always follow the basic clinical rule we all know. Try to think the questions that might be asked by your colleagues and ensure that the answers within the report. And try to describe in sequence the case presentation, the history, the physical examination, the investigations, and the patient's progress and outcome. Try also to add photographs, line diagrams, graphs, measurements, and summary tables. All of these things enhance the reader's understanding. It's very important also to obtain a written consent from the patient. We have here a checklist for the case presentation. So try to apply the reviewer's checklist. Describe the case in a narrative form. Provide the patient demographics like age, sex, height, weight, and occupation. Try to avoid the patient identifiers. For example, date of birth of the patient and the initials. Then describe the patient's complaint and list the patient's present illness. Regarding the history of the patient, list the patient's family, social, medication, allergic, and drug reaction, and try to provide the relevant finding on the physical examination that you found. Also try to provide relevant laboratory values that support your case. List the completed diagnostic procedures that are relevant and support your case. And as we mentioned before, try to provide the photographs like histopathology or X-rays, ECG, or skin manifestations that they are related to your case. And as we mentioned before, try to obtain a permission from the patient to use the patient's photograph or follow the institutional guidelines. It's very important to provide the patient's event in chronological order so that you can ensure there's like, when you're writing an abstract, there is like a temporal relationship and also like a causal relationship. And try to ensure that the case presentation provides enough detail for the reader. That's really will help you to establish the case validity. Discussion. So in the discussion section, we have to put in mind that the main purpose of the discussion is to review why decisions were made and extract the lesson from the case. And we have to keep in mind also that the best case report abstracts are those that make a small number of teaching points, even just one teaching point, in a clear and succinct language. In discussion, try to compare and contrast with the literature review that you have to evaluate the case for the accuracy and the validity and the uniqueness. Try to explain and justify the differences and the similarity, list the limitations and the relevance, and then eventually summarize the essential features to justify the uniqueness of the case and the conclusion and the recommendation. Okay. The conclusion, which is the last thing. The conclusion should be brief and not exceeding one paragraph. Justified and evidence-based. It's very important also to recommend and lost opportunities for future research. And at the end, give guidelines for utilizing information in practice, as we will see in the example right now. We have an example of a very interesting example of clinical vignette abstract that will help you through the process of writing a successful abstract from the American College of Physicians. Just give me 1 second. All right. This is an example of a clinical abstract from American College of Physicians. Okay, you can see the abstract here. And it started here with a short, descriptive, interesting title. Ergotism masquerading as arthritis. This is the title here. Followed by the author's name and its affiliation, Amy Turnover, Associate Department of Medicine, Michigan State University, East Lansing, MI. After that, you'll go to short introduction, as we talked about before, that explains the relevance of your case. In this example, we have ergotism is a condition characterized by intense generalized vasoconstriction. The infrequency with which it is encountered makes ergot poisoning a formidable diagnostic challenge. After finishing the introduction here, we move to the case description. The case description, as we talked about, is sequenced, as we mentioned, in chronological order of the history, physical investigations, and the course. Here is the case description of this case. A 34-year-old woman consulted for her doctor because of headaches, dyspnea, and burning leg pain. A clinical diagnosis of stenosis was made. Within a month, she had a cardiac catheterization because of a progressive dyspnea. At catheterization, severe mitral stenosis was confirmed. An elective mitral valve commissurotomy was scheduled. Then she presented to the hospital 1 day early because of increased burning in her feet and a new onset right leg pain. You can see here the chronological sequence of the case. In addition to the mitral stenosis, the physical examination, here's the physical examination, revealed a cool, pulseless right leg. An arteriogram showed subtotal stenosis and a pseudoaneurysm of the popliteal artery. At the time of the commissurotomy, a right femoral artery balloon dilation followed by a patch graft repair of the stenosis was performed. On the 5th day, post-operative day, she experienced a return of the burning leg pain, and the leg was again found to be cool and pulseless. An emergency arteriogram showed smooth segmental narrowing and bilateral vasospasm suggestive of severe generalized large vessel arteritis. And here's the treatment. The treatment was initiated here. The treatment they started here with a high-dose corticosteroid with anticoagulant and antiplatelet drugs and vasodilators. Despite this, after giving all of these medications and the treatment management, her condition worsened, with both legs becoming cool and pulseless. So, after that, an additional history revealed that she had been abusing ergotamine preparations for a number of years to relieve chronic headache symptoms. She continued to receive these medications during hospitalization, the ergotamine preparations here. So, at this point, the ergotamine preparations were discontinued and intravenous infusion of nitroprusside was begun. They changed the treatment plan, resulting in significant improvement just within 2 hours. And her symptoms completely resolved within 24 hours. So the patient remained symptom-free after the nitroprusside was discontinued, and was discharged from the hospital. So the discussion emphasizes the lesson of the case. So this case illustrates that the potential for severe vascular ischemia with the use of ergotamine and the value of a complete history. Although the ischemia seen in this patient is rare, and it was a predictable side effect of ergotamine use, recognition of this syndrome is critical to institutional of appropriate therapy and prevention of ischemic necrosis of an extremity. And as you can see here, the abstract fits inside the box. And this is a perfect example by the American College of Physicians for the writing an abstract. Thank you, everyone. Do you have any questions? Hello?
Yes, thank you so much. Thank you.
Do you have any questions?
Thank you again, Dr. Hassan. This is another great presentation. Excellent. Thanks for sharing. So hopefully we will be able to work on some of the cases. So there are two options. One of them is to do the abstract, and one of them is to submit it for a journal. And it's a good example that you mentioned. So thank you very much.
Thank you, Dr. Nader, for giving me this opportunity. And thank everyone for listening.
Dr. Hassan, I think Shaima asked you a question on the chat.
Okay. What was the question?
Do we need the patient's consent for a radiology case?
Yes, we need the consent for the patient before we start the thing, or there is something called constitutional guidelines we could follow if we can't find if we can't obtain the consent from the patient. But it's better to obtain a consent from the patient.
Okay, thank you.
You're welcome. You're welcome, Shema. Any other questions? All right. There you go, Dr. Nader. Thank you so much, everyone.
Thank you. And if no questions, we can move on to the next agenda.
Our last topic for the day, it's going to be Dr. Arij Shafei, and it's going to be T sample testing, or T testing and stats.
Assalamu alaikum, everyone. How's everyone doing? I will try to be as concise as I can, and I will try to dumb everything down because I know everyone's getting tired by then. Just give me 1 second.
While Arij is loading the screen. So there's one question here. Is it advisable to make an abstract or publish a case in a journal as a book? So the easiest and faster way to do it is through abstract. So you write it, you finish it, you submit it to a meeting or conference, and hopefully they will respond faster and you can present it in the conference or the meeting, which is a good step. It's fast. The other option, if you want to publish it in the case report in a journal, then you will need to put a lot of details of the manuscript itself with a lot of references and you submit it, and there is a chance that they will ask you to revise it, then you resubmit it. It may take longer. So it depends on how you want to do it. Thank you. Go ahead, Dr. Arish.
Okay. So let me see. Okay. So we're going to be talking about t-tests in biostatistics. I know this is a hard topic for a lot of IMGs. So I will try to dumb it down as much as I can, mainly for myself. So we're going to be talking about t-testing. T-testing is a statistical test that compares the mean of two different groups, okay? Mean being the average. And we want to determine if the unknown population means of two groups are equal or not. Now, we can use it to answer two questions, okay? One being whether the mean of two groups are different from each other. And the other one is in a hypothetical setting, to determine, example, whether a process or a treatment is effective in the population of interest, okay? Now, I mentioned hypothesis, and you may have heard the terms null hypothesis, which is H0, or alternate hypothesis, which is H1, or sometimes HA. So I'm going to try to say it in a very simple manner. So null hypothesis basically means this is the accepted fact, okay? This is what everyone believes in. And scientists, what they do is they try to disprove this hypothesis. They try to nullify it, hence the name null hypothesis. Now, alternate hypothesis is just means if the null hypothesis is rejected, like what's the alternative, okay? Now, what do I mean when I say is the true difference between this group means is zero? By being zero, meaning absolutely no way that this isn't the reason or this isn't the hypothesis, versus alternate hypothesis does not equal to zero or is different from zero, meaning maybe there's an alternative reason or another explanation for this. And I think we'll understand this more when I go through examples. Now, where or when can we use this t-test? We have two different definitions basically for this, or two different groups. We have independent population and then dependent population. By saying independent population, it means that our data are randomly sampled from two normal population and two independent groups, and they have equal variances. Basically, example, we want to check the mean blood pressure between males versus females, okay? There are two different groups, okay? Or data collected is dependent. Dependent meaning they're connected some way. Example, we want to check the effect of our blood pressure medication. So we collect our data for those who for our patients before and after the medication. So our population is the same people, okay, versus two separate groups. I hope that kind of makes sense. And if you notice that I'm only talking about two groups, I'm only comparing two groups. If we want to compare more than two groups, example would be blood pressure, average blood pressure among ethnic group, such as Caucasians versus Blacks versus Hispanic, then we would use a different type of method, such as ANOVA, which is analysis of variance, or others, okay? Now, so if our study group comes from a single population, such as measuring our blood pressures before and after medication, then we perform a paired t-test, okay? And if our data comes from two different populations, such as, or two different species, such as two different plant species, if we want to compare the height, or medications from two different, sorry, not medications, blood pressure from two different countries, then we would do a two-sample t-test, okay? If there's one group being compared against a standard value, such as comparing acidity of liquid to a neutral pH of 7, then we perform a one-sample t-test, okay? In order for this test to be valid, data collected must be independent. Measurements for one observation do not affect measurements for any other observation. Data in each group must be obtained via random sampling, okay? And data must be normally distributed. The values must be continuous, and then the variances between the two independent groups are equal. Okay, so when choosing a t-test, like I said, we want to see whether it is dependent or independent. Independent, like I said, we're comparing two separate populations that have nothing to do with each other, versus dependent, they have something that's linking them together. And then our other question is, we want to know the results, like which direction it goes. I know it sounds weird, but just give me a second, all right? So let's say we have, okay, I can phrase the question in either two ways. The first question could be the effect of blood pressure medication among this population. So our outcome is either going to be their blood pressure increases or decreases. For simplicity's sake, let's ignore the staying the same. It could either increase or decrease, because I just said, what's the effect in general? And that is called two-tailed t-test. There's two different outcomes. Versus if I say whether this blood pressure medication is going to reduce the average blood pressure in the study group population, we are just focusing on whether the blood pressure decreases or not. And that means it's a one-tailed t-test. I hope this makes sense, okay? When performing a t-test, the t-test estimates the true difference between two group means using the ratio of the difference in group means over the pooled standard error of both groups. You can calculate it manually using a formula or using statistical analysis software. Now, I'm only going to give you one example, and then we're going to go and kind of do like questions on Google spreadsheet. But here's an example. We are comparing students who speak English as their first language versus those who don't. Okay, so we all give them a test and we give them a score. The two groups are the native English speakers and the non-native English speakers, okay? And the measurements are the test scores, right? Now, our hypothesis is that the mean test score for the underlying population of the native versus the non-native English speakers are not going to be equal. We would assume that the native speakers are going to score higher than the non-native, right? And we want to know if the mean score for the population of native English speakers is different. So this is our hypothesis, and we can essentially collect our data and then kind of figure that out. I think things will get more clear once we practice a question. Just give me a sec. Okay. I'm going to start with this question first. I think it's a bit easier. So here you can see we have a group of individuals, okay, A to H, and we have their weight before diet and weight after diet. Now, our question is this diet effective for weight loss? Okay. My question to the group right now, is this going to be a one-tail t-test or a two-tail t-test? if anyone can answer me. So I want to know if this diet is effective for weight loss. Is it one-tailed or two-tailed? Okay, I think most people are doing one-tailed. Okay, yeah. I wouldn't say it's one-tailed because I'm not specifically asking for, okay, sorry, just give me 1 second. Everyone is saying one-tailed, okay. From my understanding is that it's supposed to be a two-tailed t-test because I didn't really see, well, yeah, okay, I'll go with one-tailed t-test. I'm a bit confused myself, so it's a learning curve for both of us. Okay, so I'm gonna show you how to analyze this through two different methods. Our first method is going to be the manual, I guess, and it's kind of, we just need two informations to get. We want to calculate the mean, and we want to calculate our test, our t-test. So first, I'm going to write mean, just to kind of label things. We want to know what our t-test is. And then it doesn't hurt to just to write what the p-value is, okay? So we know our standard p-value is usually 0.05, right? Now mean, the way that we do it, we're gonna do a function. You can either write it down here or you can write it up here. I prefer writing it down here because when I write up here, it kind of obstructs my view. And in order to do a function, you would start with equal first. Now, what do we want? They automatically assume I want the sum. I don't, I want the average. So I will write average, and then I will click on, it kind of automatically detects it for me. Click on the average. And then I will go to this bar, equal, again, average. Now, our question right now, I'm looking at this. Do you guys see a difference? We do, right? Weight before diet, the average is 187 pounds versus 180 pounds. So there is a bit of weight decrease. But the question is it statistically significant, okay? And that's where our t-test comes in, okay? So I would do equal t dot test, okay? Now, it's gonna ask you for your range. So we wanna do weight before diet, click on the first tab or first cell, and then click on shift, and then click on the last one, okay? Comma. We want to do, compare it with our weight after diet. What's cool about this is they kind of guides you a little bit. So shift, click on the second one, okay? Now, the reason I do say it's two tails, only because our weight here in E has increased a little bit. So we have like an anomaly here. Hence why I'm saying is a two tail, because it does increase. I know the question basically is saying effective meaning weight loss, but just for our sake, we're just gonna write that. Now, okay, type, what's this? Okay, so I mentioned before something called independent versus dependent group. Independent, which basically means they're not related to each other. So independent would be different groups of people before diet, and then be different groups of people after diet. Now, independent would have the number 2. It's just something you have to learn, the number 2. Dependent, meaning you're checking or collecting our data from the same population before and after. So we would do 1, okay? And then there's like a number, which is 3, which basically just means variance are not the same. And just ignore that. Just remember the function 1 and 2. And then we would click equal. You will see that our t-test is 0.04. Now, how do we interpret this? Okay. We will say, we will look at our t-test. So our t-test is 0.04. Let's say 0.047. Let's just leave it like that. Is it less than or equal than or greater than our p-value? Just someone quickly write it in chat. Smaller, right? So it's going to be less than our p-value. So what does that mean? It means that here, our null hypothesis, it's showing us there is a difference, right? Our t-test is less. Anything less than our p-value means it's significant. So meaning that weight, that diet, this specific diet does significantly or statistically significant for weight loss, okay? I think I forgot to mention what this is. Okay, null hypothesis, we kind of mentioned it. Null hypothesis just basically mean that there is no difference. So our diet is not going to affect the weight. An alternative hypothesis, it means that our diet is going to affect the weight, or yeah, it's going to cause weight reduction. So because our t-value is less than our p-value, it means is statistically significant, meaning this diet affected the weight. So we will reject, we're going to reject our null hypothesis. So this is going to be rejected, and we're going to accept our alternative hypothesis, basically saying that this diet will cause weight reduction. Now, I have an easier method of doing this, which is we are going to go to extensions. Now we're going to go to something called add-ons, and you're going to click get add-ons. And these are all free and is basically similar to our Microsoft Access or Excel sheets. And we're going to download something called Excel Minor Analysis Tool Pack. Now I already have it downloaded. Just click on it and install it. It is for free. Again, then we're going to go to extension add-on, and you're going to do view document add-ons. And this is what we're going to use. Okay. What's cool about this, it kind of does all the work for you. The only thing you really need to know is whether it is a paired or unpaired. Okay. Paired meaning there's some connection between them. Paired or dependent are both, they mean both the same thing here. So let's click on paired to sample for means, okay? Variable 1 range. Now, notice that I straight away highlighted our B15 cell. It just basically, whatever cell you click on, it automatically jots it down there. So just ignore that for a second. You're gonna click from the title, shift, and down to H, or down to cell 9. And then click on variable range 1, and it will automatically correct itself. And then again, we're going to go here, shift, and then variable for range 2. We want the labels, okay? And then output range, let's say I want the results to be displayed here. So output range, I will click on which cell I want the results to be displayed, which is A16. Now click OK. And then it kind of gives us all the information and more. So we will look at it here. So weight before diet, weight after diet, it calculated our mean for us. God bless, which is exactly what we got here. And then our two-tail, which is right here, 0.047, 0.047. So that's just kind of, I guess you would say, a shortcut. Okay. I hope everyone understood that. Sorry, I know I'm a bit confusing, but I tried to really explain it in a very simple way. Here's another example. We have plants. We have species 1, and these are their heights, and species 2, and these are their heights, okay? And you want to compare the mean height difference between species 1 and species 2. Now, like I said, what's the first thing that we're going to do? We want to know if it is a independent or dependent group values, or another terminology is unpaired or paired group. Can anyone answer that question? I'll remind everyone again, unpaired means that they have no common link between them, while paired meaning they do. So unpaired would be males versus females. Unpaired, yeah. Independent, good. Okay, at least some people are paying attention, okay. Yeah, good job, everyone. Yeah, it is unpaired because these are 2 different species, right? Now, again, I really want to send this on the group and I wanted everyone to do this, but it's okay. So let's start by doing, we said we're gonna do the mean. Let's do mean. We want to do the t-test and then p-value. It wouldn't hurt, right? Just have all your information written there. So mean is going to be, can anyone just tell me quickly, what am I supposed to write here? Grand. Y'all are legends. Okay. Don't forget the equal sign first, okay? Okay. Yeah. So it's going to be equal average. Okay. Oopsie. Okay. And then look how it automatically kind of detects it. So the computer is pretty smart, okay? I believe it's tab. Oopsie, that's my bad. Oh, yep, that's ground. And then again, equal average. And then tab. Now you can see it's 15.15 for species 1 versus 15.8 for species 2. Now we want to do t-test. So can anyone tell me? Can anyone like just write the whole thing? I'm really curious. Okay, we'll start with t.test. Oopsie. T.test. Okay. And then ground. Let's do that. Oh, God, gosh, my bad. Okay, so sorry, t.test. One. And then it's going to be here, shift here. Okay. And how many tails? That's my question. Tails number 1 or 2. So which one is it? And let's look at the question again. The question is, compare the mean height difference between species 1 and 2. So it just says compare. So what does everyone think the tails is going to be? Is it going to be 1 tail t-test or 2? And I'll remind everyone of the definition again. 1 tail t-test, I would put a specific thing like whether we want it is species 1 taller than species 2 versus 2 tail, I'm just comparing the mean. So it could either be taller or shorter. So which one is it? Yes, I think people are switching to 2. Yeah, everyone's right. It's 2. Grand. So it's 2 tails, comma, type. So I said unpaired is 2, paired is 1. So which one is this again? Unpaired. You guys are awesome. Yay. Okay. Yep. Now here's our answer. Our t-test is 0.53. Can anyone interpret this for me? Okay. So our t-test is 0.53 and our p-value is 0.05. Shema said not statistically significant. H0, our null hypothesis nullified. Yes, you guys. Okay. It's not significant. I'll tell you why. Because our t-test is actually greater than our p-value. Okay. It's not significant. Okay. Now you may ask me, can we do it the extension way? Now I'll tell you we can't, or I haven't been able to figure it out. And I'll tell you, actually, I'll show you. Because if you look here, here we have is the paired 2 sample for the means, paired. And I haven't found unpaired. Certain people say you can use the 2 sample assuming equal variances, but my answers have been different. So I would just stick to this method. It's kind of straightforward. If anyone wants to do one more question, then you have it right here, if anyone's interested. If anyone can kind of just tell me quickly. So our question is, do medical procedures cost the same at different hospitals? So is this paired or unpaired? Okay. Okay. Are we going to be doing 2-tailed or 1-tailed? Okay. 2-tailed is right. Whether it's paired or unpaired, funny story is, the person who gave this example said it is going to be paired. I disagree. I'm just letting everyone kind of know, just because the hospitals are in 2 different places. But I'm just letting everyone know. Okay, so let us just do it the easy way. So we're going to do mean. Someone write it down what we're supposed to do. P-value and t-test. Mean. Yes, good job. Average. Here we go. Grand. Okay. P-value is going to be 0.05. What about this one? This one's a little, okay. Range 1, 2, and then range 2. Okay. Tails, we said it's going to be. Good job, everyone. Type. Yeah, this is what I agree with. I do agree that it is paired. If paired, it's unpaired. because they're not, they don't. Anyways, so our t-test is going to be interpretation quickly. It's the last question. Who can interpret this for me? Our t-test is 0.3 and our p-value is 0.05. H0 is rejected because no, who says statistically significant? Our t-test is 0.3. Yes, it's insignificant because our t-test is bigger than our p-value. Now, funny story, like I said, is the guy who did this question claimed that this is going to be paired, and I haven't been able to understand why. So when you do it as a paired sample, our results is 0.0056, which means what? It means in this example, there is a significance. So it would mean that there is a difference between medical procedure costs. But that's about it. I am sorry if I confused anyone, but I think a lot of you guys got the hang of it towards the end. If anyone has any questions, let me know, but I am done. Thank you for listening.
If anyone, you guys don't have any questions, I do just want to add one last point to Arij's presentation, and it's the variance. So I'm just going to share my screen. This is probably going to take a minute. This one, yeah. Can you guys see my screen?
Yeah.
Okay, perfect. So, so this is a paired t-test, just like how Arij mentioned. One of the most important ways is, or one of the prereqs to have t-testing among two groups is to have sort of equal variances. Now you can calculate it using this formula, but we're very lucky that you can do it through Excel. So, you know, again, you'd go through your data analysis and you would use this F-test2 sample for variances. And you'd input your ranges. So the variable 1 range would be, you know, your English speakers, or what your first range is. Your second, just input these real quick. And then let's say we're going to put it here. Come on. Sorry, guys. Okay, it's not complying. Let's try that again. My output range. I'm going to stop. I have another example. Okay, it's been more than a minute. I apologize. D1 to D11. Let's do that. Okay. So if you look at this, you're looking at the variances, and at first glance, that's a big difference for these two sets. And so you immediately think to yourself, oh, the variances are unequal. And so maybe t-testing isn't appropriate for this. But if you go down and look at the p-value, it's 0.09. which means that although there is a great variance between the two, or there's a big difference, there's a 9% chance that these two are the same. And so basically equal variance. And so you can go ahead and calculate that. So that's the only thing that I wanted to mention. Instead of using the manual formula, you can use the F-test for variance, equal variance. And that's it. Thank you.
Thank you so much, both Salman and Rich. It's great and concise and to the point. Thank you. Hopefully this will help. So statistics, sometimes it's straightforward, sometimes it's a little bit tricky. So I think it's one of those things, if you want to practice on it, improve on it, then you can get the hang of, like, you will be familiar, and you can do many things. So if you don't practice it on the other side, then it will be a little bit far from what's going on and hard to use. Thank you, both of you. If no other questions or comments, we can move to the next meeting agenda. I think the meeting for next week. Review the grade team. So if the top of mind here or one of the group, one of the team, the grade team, we're gonna work on the next week presentations. So I put some names, and if people are busy or unable to participate, let the team leader know so that someone else will carry on. Thank you so much. Before we end the meeting, do we have any updates as far as corrects? Any questions, any comments, anything? If not, then thank you so much, Dr. Salman, for moderating the meeting, and thank you, everyone, all the presenters. Thank you. Okay, Dr. Sahar, go ahead.
Thank you, Dr. Nader. I will just I will try to send the presentation for you, just if in case if anyone interested. I will share the presentation with you. I'll send it with you through the link. Thank you, everyone.
I appreciate it. Dr. Sahar, I think, comment or question? If not, that's fine. So, thanks. Yeah, go ahead.
I'm not sure.
Amal, go ahead.
Dr. Nader, I wanted to ask about the Sparrow Hospital internal medicine rounds. I don't understand the idea. So can you please elaborate more on that?
So in the last couple of years, they used to have on Tuesday at noon o'clock New York time, they spent 1 hour for discussion of presentation of the grand rounds. So they had some topics so each week, but during the COVID, they made it every 2 weeks. They have the grand rounds. So in the past, we have a schedule. So I shared it with previous fellows. I did not get the updated schedule. So usually, I think they start in August. So in the next few days, I hope I will get the updated schedule. So for you guys, when this is updated, it will be on the app. If you scroll all the way down, you'll find it, the link for the grand rounds, and you can click on that when it's like online. on Tuesdays. The other option, also some of you might be interested in neurology. So also the Department of Neurology, they have their own grand rounds and they start at 7:30 in the morning on Fridays. So I didn't get the schedule for them as well. When I get it, I will update the app. So you'll have that also available. Thank you for asking.
Thank you so much, Dr. Nadir.
Next one. Okay. If no questions, then we will see you next week. Thank you, everyone. Have a wonderful day. Have a wonderful night wherever you are. And we'll see you. Thank you.
Thank you.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir. Thank you,
so much,
everyone.
Dr. Nadir.
Thank you, everyone.
Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir. Thank you. Bye.